Imagine a patient walks into your clinic. She's a 51-year-old woman. She looks a bit pale, maybe a bit washed out, tied around the eyes.
Right.
Her chief complaint, the thing that actually made her book the appointment, is breathlessness. She tells you she gets winded just walking up a single flight of stairs.
Okay, so your mind immediately goes to the chest.
Of course, you're thinking heart failure, maybe a respiratory issue like COPD, or perhaps a silent myocardial infarction. That's the standard algorithm.
It's the logical place to start. Breathlessness usually equals heart or lungs.
Exactly. So you pull out the stethoscope, you listen to the heart clear rhythm, no murmurs. You listen to the lungs clear entry on both sides. You check the oxygen saturation. It's perfectly normal.
So the chest is clean.
The chest is innocent. But then you look closer at her face. Her lips are pale. Her conjunctiva, the inner lining of the eyelids, is pale. She's profoundly anemic.
Okay, so she's losing blood from somewhere.
Or not making enough. So you ask about her digestion, and she admits, a little embarrassed, that she's been constipated for years and frequently passes blood-stained stools.
And that is the pivot point, the twist in the story.
The culprit isn't in the chest at all. It's at the complete opposite end of the torso. You do a proctoscopic exam, and there they are, 3 congested, angry-looking swellings at the 3, 7, and 11 o'clock positions.
Massive internal hemorrhoids.
Yes. They've been bleeding slowly, drop by drop, for years. It caused severe anemia, which caused the lack of oxygen transport, which in turn caused the breathlessness.
It's such a classic clinical lesson. The body is a unified system. A structural failure in the basement of the pelvis can, turn off the lights in the attic of the respiratory system.
And that, my friends, is why we are here today. We are doing a deep dive into the basement. We are exploring the perineum chapter of Snell's clinical anatomy.
A region that is, I think, often rushed through in dissection halls because it's complex, it's messy, and frankly, it can be a bit socially awkward. Right. But clinically, it is absolute gold. Whether you are going into emergency medicine, surgery, obstetrics, or urology, you simply cannot escape the perineum.
So before we descend into the anatomy, a quick note to you, the listener. What you are about to hear is our interpretation. Think of this as a ready reckoner, a guided audio tour to help you visualize these complex 3D structures.
Yeah, this is not a replacement for the book. Not at all.
No, we can't stress that enough.
Correct. Reading is becoming a bit of a lost art, which is a tragedy for deep learning. We really want this discussion to be the spark. We want you to finish this deep dive, grab your copy of Snell's, and actually look at the diagrams with fresh eyes.
We're giving you the map. You still have to walk the territory.
Exactly.
So our mission today is to map out that diamond between the thighs.
Okay.
We need to understand the triangles, the pouches, and why a bicycle accident can make your stomach turn blue.
I love that image. Let's set the stage with a metaphor. If the abdominal cavity is the main living room of the house, and the true pelvis is the ground floor, then the perineum is the basement.
I like that. It helps localize it immediately.
And separating the ground floor from the basement is this muscular ceiling called the pelvic diaphragm, specifically the levator antemuscles. Everything below that muscular sheet is the perineum.
Okay, so we are completely below the pelvic floor. Got it. Let's map the boundaries. Snell describes the perineum as a diamond shape. But to see the diamond, we need the patient in a specific position, right? You can't just see it standing up.
No, absolutely not. You need the lithotomy position. This is standard for pelvic exams, childbirth, urological procedures. The patient is lying on their back, hips flexed, knees bent, and thighs abducted, spread apart.
So in that position, if you look from below, the surface anatomy clearly forms a diamond. Let's trace the 4 corners of this diamond for everyone listening. Visualize this. At the front, anteriorly, you have the symphysis pubis.
Right, that's the bony joint at the very front of the pelvis where the 2 hip bones meet.
And at the back, posterior, is the tip of the coccyx, the tailbone, and on the sides.
On the sides, you have the ischial tuberosities. These are the sit bones. I mean, if you are sitting on a hard chair right now listening to this, the bony points digging into the seat are your ischial tuberosities.
Symphysis pubis front, coccyx back, sit bones on the sides. That's our diamond. Now, to make this manageable, anatomists draw an imaginary line connecting the 2 sit bones, basically slicing the diamond horizontally in half.
Exactly. This transverse line creates 2 triangles. The anterior half, the front triangle, is the urogenital triangle. That contains all the external genitalia and the urethra.
And the posterior half.
That's the anal triangle. And it contains, well, the anus.
Simple enough.
Yeah.
But before we jump into those triangles, there is something right in the middle of that imaginary line, a central hub. Snell calls it the perineal body.
Oh, this is so important. Think of the perineal body as central station or the keystone of the pelvic floor. It's this fibromuscular mass right in the geometric center of the perineum.
Why is this little knot of tissue so important? Sounds kind of unassuming.
Because almost everything anchors to it. You have muscles from the front, muscles from the back, and muscles from the sides all converging and attaching at this one point. In women, it lies right between the vagina and the anal canal.
So structurally, it's really holding things together.
Absolutely. If that keystone crumbles, say, due to a severe tear during childbirth, the structural integrity of the entire pelvic floor is compromised, you can end up with prolapse, where the pelvic organs literally start sinking because their central anchor point is just gone.
It's like cutting the central pole of a tent.
Perfect analogy. The whole thing sags.
That is a crucial visualization. It's the knot that ties the whole mesh together. Okay, let's tackle the posterior part of the basement first, the anal triangle.
Right. This region is dominated by the anal canal in the center and these two massive fat-filled spaces on either side called the ischianal fossa.
Let's zoom in on the anal canal itself. Snell mentions it's only about 4 centimeters long. It seems so short, but the anatomy here is incredibly dense.
It is. And the most critical concept to grasp here, I mean, if you take nothing else away from this whole section, take this, is the pectinate line.
The pectinate line. Okay, that sounds like a border crossing.
It is exactly that. It's an embryological border. The anal canal is kind of a Frankenstein structure. It's stitched together from two completely different origins.
Okay, let's unpack that. What do you mean?
Well, the upper half of the anal canal comes from the hindgut. That's endoderm. It's basically the very end of your intestine.
Okay.
The lower half comes from the skin, the ectoderm, which invaginates. It folds inwards from the outside during development.
So the upper half is gut, and the lower half is skin. And they meet right at this pectinate line.
Precisely. And because they come from two totally different worlds, they follow different rules.
Yeah.
And this dictates everything from cancer spread to, how much pain you feel.
Let's break down those differences. Start with the lining, the epithelium.
Okay. So the upper half, being gut, is lined with columnar epithelium. Simple. The lower half, being skin, is lined with stratified squamous epithelium. It's tougher.
All right, lining is one thing, but what about sensation? This is where the critical gold is.
This is what matters to the patient, 100%. The upper half has autonomic nerves supply visceral nerves. Just like your intestine, it is totally blind to cutting or burning. You could snip a piece of the upper anal canal, and the patient wouldn't feel sharp pain.
But it's not completely without sensation.
No, it's sensitive to stretch. That's why gas or fullness feels like pressure, not like a cut.
Right. Now, what happens when you cross the border to the lower half?
Well, now you're in skin territory. It's supplied by somatic nerves, specifically the inferior rectal nerve. And it is exquisitely sensitive to pain, touch, and temperature. Everything.
This distinction is huge. It completely explains why some anal conditions are just a dull ache and others are screaming agony.
And it doesn't stop there. It explains the blood supply and lymph drainage, too.
Okay, go on.
The upper half drains into the portal system, meaning the blood goes to the liver first. The lower half drains into the systemic veins, so it goes straight back to the heart.
And the lymph nodes?
Upper half drains deep to internal pelvic nodes you can't feel. The lower half drains to the superficial inguinal nodes, the ones you can actually palpate in your groin.
So if a patient has a cancer in the lower anal canal, you might feel a lump in their groin.
Exactly. But if the cancer is just a centimeter higher above the line, the groin nodes will be totally normal, even if the cancer has spread deep into the pelvis. It's a vital distinction.
Wow. Okay, let's talk about the doors to the basement. The sphincters. We have two, right?
We do. The internal and the external sphincter. The internal sphincter is just a thickening of the smooth muscle of the gut wall. It's involuntary. I call it the night watchman.
The night watchman.
Yeah, it stays tight automatically to keep us continent while we sleep or go about our day. We don't have to think about it.
And the external sphincter.
That is skeletal muscle. It's voluntary. It's supplied by that same inferior rectal nerve, the somatic one. This is the emergency brake. When you feel the urge to go, but it's not the right time, you voluntarily clench this muscle to override the reflex.
Snell also mentions a muscle called the puborectalis. It forms a kind of sling.
Yes, the puborectalis is technically part of the pelvic floor, but it loops around the junction of the rectum and anus like a sling. And what it does is it pulls the junction forward, creating a kink and angle.
Like a kink in a garden hose.
Exactly like that. It acts like a valve. When you squat to defecate, the sling relaxes, the kink straightens out, and things can move.
Brilliant. Simple mechanics in action. Now let's apply all this anatomy to some clinical case studies. We mentioned the anemia case in the intro hemorrhoids.
Right, hemorrhoids are piles. They're essentially varicose veins of the anal canal, but their location relative to that pectinate line changes absolutely everything about how they present.
Okay, let's differentiate.
Oh.
Internal hemorrhoids.
These are varicosities of the superior rectal vein, located in the upper half of the canal. So remember the nerve supply.
Autonomic. No pain sensors.
Exactly. So internal hemorrhoids bleed, often profusely, bright red blood, but they're usually painless. The patient sees a lot of blood in the bowl but didn't feel a tear or any pain.
And Snell gives a very specific location rule for these, the 3-7-11 rule.
Right. Because of the anatomy of the superior rectal artery, the veins naturally form three main trunks. If you view the patient in the lithotomy position like looking at a clock face, these trunks bulge at the 3, 7, and 11 o'clock positions. That's where you look first for primary internal hemorrhoids.
Okay, now contrast that with external hemorrhoids.
These are in the lower half, below the line. They involve the inferior rectal vein. And because this area is supplied by those somatic nerves,
It hurts a lot.
they are excruciating. If an external hemorrhoid thrombosis gets a blood clot, it presents as this hard, incredibly tender blue lump right at the anal margin. The patient literally can't sit down.
So, quick check-in for the listener. Pause for a second. If a patient comes in with a mass at the anal margin that is excruciatingly painful to the touch, is it likely an internal or external hemorrhoid?
Think about the nerves.
Yeah.
Pain equals somatic. Somatic equals the lower half. So it has to be an external hemorrhoid or maybe an anal fissure. If it's bleeding but painless, you have to think internal.
If you didn't get that, rewind a minute and listen to the nerve supply section again. It really is that critical.
It is.
Let's move to another fictional case. Let's call him Steve.
Yeah.
Steve is an avid cyclist. He comes in complaining of this deep, throbbing ache on the right side of his anus. He's running a fever. It hurts to sit on his bike saddle, obviously, but it also just hurts to walk.
Yeah. This sounds like trouble in the ischial fossa.
Describe this space for us. What is it?
So flanking the anal canal on both sides are these large wedge-shaped spaces. They're called the ischial fossae. The base of the wedge is the skin of the buttock. The inner wall is the anal canal itself.
And what's inside them?
Fat, just dense, semi-liquid fat.
Why fat? What's its purpose?
Think of it like packing peanuts in a box. The anal canal needs to expand significantly during defecation. If it were surrounded by rigid bone or muscle, it couldn't open properly. The fat in the ischial fossa just squishes out of the way to allow passage.
Okay, so Steve has these fat-filled spaces. Why is he in so much pain?
Because fat has a pretty poor blood supply, and this whole area is right next to the anus, which is full of bacteria. So if a small gland in the anal wall gets blocked and infected, the bacteria can burrow out into this fat. The infection just spreads like wildfire in the fat, forming an ischioanal abscess.
A deep pocket of pus.
A large, deep, very painful pocket of pus. And here's the real danger Snell points out. The two fossa, the left and the right, they communicate with each other behind the anal canal.
They're connected.
Yes, through a space called the deep posternal space. So an infection that starts on the right side can actually track behind the anus and spread over to the left side.
Creating a horseshoe shape.
Exactly. A horseshoe abscess, it wraps around the back of the anal canal. And surgically draining this is complex because you have to chase the infection all the way around the horseshoe without cutting those vital sphincter muscles.
Poor Steve. So the lesson here is anal pain with a fever and a tender buttock. Don't just give antibiotics. You need to examine for a deep abscess in that packing peanut space.
Precisely. It's a surgical emergency.
Okay, let's move forward. We're leaving the posterior basement, the anal triangle, and stepping over that transverse line into the anterior basement, the urogenital triangle.
Right, and this is where things get a bit more structural. It's very layered. Snell describes this area using a layer cake model. It's all about layers of fascia and the spaces or pouches that exist between them.
Anatomy students often dread the pouches. It feels so abstract. Let's try and simplify it.
Lex, so we have the skin. Under the skin, we have the superficial fascia. In the abdomen, this fascia has two distinct layers. A fatty layer, which is Camper's, and a membranous layer, which is Scarpa's. These layers continue down into the perineum.
But they change names, of course, just to be confusing.
Naturally, the fatty layer enters the perineum and sort of fades away or merges with that ischioanal fat. But the membranous layer scarpus fascia continues down into the perineum and becomes collisus fascia.
Collisus fascia. Okay, that's a name to remember.
It is the crucial boundary. Collis fascia is this tough membranous sheet that covers what we call the superficial pouch.
So what is the superficial perineal patch?
It's the space between collis fascia, which is the floor, and another layer called the perineal membrane, which is the ceiling.
And the deep perineal pouch?
That is the space above the perineal membrane.
Okay, so the perineal membrane is the divider. Below it is superficial, above it is deep. Why does this all matter? Let's put it in a clinical scenario.
The classic board exam question. A straddle injury. Imagine a young man, he's trying to climb a fence and falls or crashes his bike, landing hard on the crossbar right between his legs.
Ouch.
He ruptures the spongy urethra inside the bulb of the penis. Now you have to remember the bulb of the penis sits in the superficial pouch.
So urine starts leaking out of the urethra. Where does it go?
It fills up the superficial pouch. It's trapped under collis fascia. Now, the thing about collis fascia is that it's attached firmly to the back of the perineal membrane, so urine can't go backward towards the anus.
Okay.
And it's attached to the sides on the pubic bone, so it can't go into the legs.
Wait, it can't go into the thighs at all?
No. The fascia fuses with the deep fascia of the thigh, the fascia lata. It's a complete seal. So the urine has only one way to go, up.
Up, towards the belly.
It flows into the scrotum, making it huge. It flows along the shaft of the penis, and then it flows up the anterior abdominal wall deep to scarpus fascia.
So you get this really distinct pattern of swelling that looks kind of like a pair of shorts.
A very specific shape. A swollen scrotum, a swollen penis, and swelling that rises up towards the belly button. But, and this is the absolute key, the thighs are normal, the back is normal.
That is the urinary extravasation pattern. It's basically a map of collis fascia.
Exactly. If you saw urine in the thighs, you'd know the fascia itself was torn or the injury was much deeper. But typically, the thighs are spared. It's a beautiful clinical sign.
Fascinating. Let's stay with the male anatomy for a moment since we're on the urethra. Snell breaks down the penis into 3 cylinders of tissue.
Right. You have 2 corpora cavernosa on the top, the dorsal side. These are the main erectile bodies. And you have 1 corpus spongiosum on the bottom, the ventral side. And the urethra runs through the spongiosum, hence the name spongy urethra.
And the tip of that corpus spongiosum expands to form the glans penis.
Correct.
Oh.
Now, navigating this urethra with a catheter requires a bit of geometry.
The famous S-curve.
Exactly. When the penis is flaccid, the urethra makes 2 bends, forming an S shape. One bend is at the root, and one is where the penis hangs down.
So if you just try to shove a catheter in, you're going to hit the wall of the urethra at that first bend and cause a lot of damage.
Or create a false passage, which is an absolute nightmare to deal with. The trick to catheterizing a male is you must hold the penis upright perpendicular to the body. This straightens out the first bend, turning the S into more of a J.
Turn the S into a J. That's a great anchor.
And then the catheter can slide much more smoothly up towards the bladder.
Now, what about the danger zone that Snell warns about?
The membranous urethra. This is the really short segment that passes through the deep pouch and the external sphincter. The key thing is that it's narrow and it is fixed. It doesn't move.
So if you're too aggressive with the catheter,
the tip can puncture right through the bulbous urethra just before it enters that fixed membranous part. Gentle, steady pressure is always the rule.
let's talk about the nervous system control of the male genitalia, erection versus ejaculation. There's a mnemonic for this that everyone uses.
Point and shoot. It's a classic.
Break it down for us.
Okay, so point refers to erection. P for point, P for parasympathetic.
So the parasympathetic nerves coming from S2, S3, S4 are responsible for getting things started.
Yes. They cause vasodilation. The Helicine arteries open up, blood rushes into the cavernous spaces, fills them up, and the penis points.
And shoot.
Shoot refers to ejaculation. S for shoot, S for sympathetic.
The sympathetic nerves from L1 and L2.
Right. They trigger the smooth muscle contraction in the vas deferens, the prostate, and the seminal vesicles to expel all the fluid into the urethra.
So, point is parasympathetic, shoot is sympathetic. But wait, doesn't the somatic system play a role too?
It does. That's the final step. The final expulsion involves the rhythmic contraction of the bulbospongiosus muscle, that skeletal muscle supplied by the pudendal nerve, which is somatic. So the whole symphony. Parasympathetic to start it, sympathetic to load the gun, and somatic to pull the trigger.
That is a surprisingly complex sequence. Let's pivot now to the female urogenital triangle. Structurally, it's homologous to the male, isn't it?
It is. We are all built from the same basic blueprint.
So the clitoris
Is the homologue of the penis. It has two corpora cavernosa that form the crura and the body. It has a glans. It has erectile tissue. I mean, it essentially works the same way, engorging with blood upon stimulation.
But the corpus spongiosum is split in the female.
Exactly. In the male, the two vestibular bulbs fuse in the middle to form the single corpus spongiosum that surrounds the urethra. In the female, they remain separate as the vestibular bulbs on either side of the vaginal opening.
And we have glands here, too. The greater vestibular glands, which are also known as Bartholin's glands.
Yes, these are located at roughly the 5 and 7 o'clock positions at the entrance to the vagina, and they secrete mucus for lubrication.
And clinically, what's their significance?
They can be troublemakers. The ducts are very narrow, so if they get blocked due to infection or just some debris, the fluid backs up, forming a Bartholin's cyst.
Which can then get infected.
And become a Bartholin's abscess, which is extremely painful. So if a female patient presents with a painful swelling on one side of the introitus, you have to think Bartholin's.
And remember the position, 5 or 7 o'clock.
That's the spot.
Okay, what about the female urethra? We said the male one is long and curvy.
The female urethra is the opposite. It's short only about 4 centimeters and relatively straight.
This makes catheterization a lot easier, I would assume.
Much, much easier. But there is a significant downside. That short length means bacteria from the perineum have a very short commute to get to the bladder. And this is why women are significantly more prone to urinary tract infections or UTIs and cystitis than men.
It's purely a plumbing issue, a design flaw almost.
Biology is often just geometry.
Let's move to our final section, obstetrics. The perineum is obviously central to childbirth. Snell discusses the incredible stretching that occurs.
Yes, during the second stage of labor, as the fetal head pushes down on the pelvic floor, the perineum has to stretch immensely, and sometimes it tears.
To prevent a jagged, uncontrolled tear, doctors sometimes perform an episiotomy, a surgical cut.
Right, the goal is to widen the opening in a controlled way, but where you make that cut matters a great deal.
Snell mentions the direction of the cut is key.
Typically, it is a mediolateral incision. That means you start at the back of the vagina and cut diagonally out to the side.
Why not just cut straight back towards the anus? That seems like it would be simpler.
That would be a midline episiotomy. And some people do them, but the risk is that if the cut tears further, which can happen as the head delivers, it rips right through the perineal body, the keystone, and then it can go right into the external anal sphincter,
causing fecal incontinence.
Exactly. A devastating complication for the patient. By cutting diagonally, mediolaterally, you steer clear of the sphincter and the anal canal. You sacrifice some muscle on the side to save the sphincter at the center.
That makes perfect sense. Now, childbirth is painful. Let's talk about pain management. Snell outlines the pudendal block.
Right. The pudendal nerve, our old friend from S2, S3, and S4, is the master nerve of the perineum. It supplies sensation to most of the area you want to numb.
So to block the pain, you need to block this nerve. But the nerve is deep inside the pelvis. How does the obstetrician find it?
They need a landmark, a lighthouse in the pelvis, something they can feel. And that lighthouse is the ischial spine.
The ischial spine.
Yes. If you perform a vaginal exam, you can palpate this bony projection on the side wall of the pelvis. That is the ischial spine. And the pudendal nerve conveniently wraps right around the back of that spine before it enters the perineum.
So the doctor feels for the spine, guides the needle towards it through the vaginal wall, and injects the anesthetic right there.
Exactly. You numb the nerve before it branches out. It's a very targeted strike that numbs the whole perineum.
Let's do a quick check-in for the listener here. Visualize the pelvis. You are the obstetrician. You need to stop the pain in the perineum. Why is the ischial spine your lighthouse? What nerve are you aiming for as it wraps around that point?
Hopefully you're all screaming pudendal nerve at your speakers right now.
We've covered so much ground. From the basement metaphor to the diamond shape. From the two worlds of the anal canal to the layer cake of the urogenital triangle.
And we've seen over and over how the anatomy explains the clinical picture. Why the internal hemorrhoid is silent, but the external one screams. Why the cyclist gets a horseshoe abscess. Why the straddle injury swells up the belly.
What really stands out to me is the interconnectedness of it all. You can't just look at the surface. You have to know what fascia is connected to what bone to understand where fluid, like urine or pus, is going to go.
That is the essence of clinical anatomy. It's not just naming parts. It's about predicting pathways.
So what's the so what for our listener? Why does this chapter really matter?
The so what is that the perineum is the gateway. It's the exit for the urinary, genital, and GI tracts. Problems here, incontinence, pain, dysfunction, have a massive, massive impact on a patient's quality of life. Understanding this anatomy allows you to diagnose precisely and treat effectively rather than just, guessing.
And honestly, it explains some truly bizarre-sounding things, like why liver failure, portal hypertension can cause hemorrhoids.
Ah, yes. The portosystemic anastomosis, a classic. Since the upper anal veins drain to the liver's portal system, if the liver is blocked, like in cirrhosis, blood backs up all the way down and balloons out those veins in the anus. The hemorrhoid is a symptom of the liver.
It's incredible. It's all connected.
I want to leave the listener with one final provocative thought.
Go for it.
Consider the embryology again. The fact that we are literally stitched together, the fact that our anal canal is half gut and half skin it's a design quirk. It's a seam, and like any seam in a piece of clothing, it's a point of vulnerability and transition. It dictates how we feel pain, where cancer hides, and how it spreads. It's a powerful reminder that our bodies are living history books of our own development.
A seam that dictates our clinical reality. I love that.
We have given you the roadmap, but a map is not the territory.
That's right. Now is the time to open Snell's Clinical Anatomy, the chapter on the perineum. Look at the diagrams of the ischioanal fossa. Trace the pudendal nerve around the ischial spine. Look at the cross-section of the penis and the pouches.
The text is going to make so much more sense now that you have the story, the why, in your head.
Keep learning, keep reading. And thanks for taking this deep dive with us.
Until next time.